So there are lots of different scenarios we could use, but one of the things that's really important, and it might seem really simple, is just recognizing that the person in front of you has got chronic pain. Because when we speak to people, and the people that come to the pain clinic, their pain journey can be like 20 years before somebody's actually really recognized that they've got chronic pain. So how do you stratify and deal with this kind of massive problem? Because 1 in 5 might have the problem. So right in the beginning, pain. If the person says they've got pain, they do. It's better to have that attitude, because we do not have any tests, little fancy electronic equipment that we can actually measure a person's pain. Unless a person tells us they have pain, we don't know. And you're better off accepting that rather than diagnosing every second patient as Munchausen's. The Munchausen's will jump out at you later and you can try and figure it out. But, or somatization syndrome or whatever. It's easier just to accept that they've got it. And then, so once you've accepted that they've got it, a pain diagram is so useful, because in people with persistent pain, if they'll come to you with one problem, and as we've shown, that they may have a multitude. And if you just say to them, here's a pain diagram, just draw all the areas that you've got pain. Or sometimes I'll start from the top. Do you have headache? Do you have neck ache? Do you have shoulder? You can just run through the body. And so you suddenly develop a better picture of the site. And then the other thing about the sites is that where a person perceives they have pain is not necessarily exactly where the problem is, especially with problems deep in the body. So one of the ways to think about it, we can very accurately localize where we think that the problem is when it's on our surface, because if you think about walking through the jungle in our sensory system, that's what we needed, was sensory evaluation from fingertips and our skin. So the skin is the exception to the rule. The reason why we can locate things very accurately in the skin is that we get other sensory stimuli, and we can very, very accurately locate that. But the deeper structures, there was no value in knowing that it's exactly your appendicitis, your appendix that was causing the problem. And so that's why we get all these weird referral patterns. And so you've got to take that into account. So I normally get the people to, if somebody says to me, I've got backache, I want to know if it's a low back pain. What we've got to realize is that every description has a definition, and there's a valid definition, and then the research basis is based on that definition. So the low back is the area above the sacrum, below T12, and it doesn't extend beyond the erector spinae. So that's the definition of low back pain. So if it's over there, it's buttock pain, or if it's sacral pain, and that does have some value when you're trying to sort things out in the beginning. So you're on the same page, because if they've got pain up here, it's a different, renal, it's a whole different set of differentials. So that's just the sort of start. But the biggest thing is just the duration. So if I got a person in front of me, how long have you had your pain for? So then that immediately, if they've had it for, the 3 to 6 months, and especially years, that immediately puts them in that chronic pain camp, and you can start to relax. So at primary care, this is all good. And, practice nurses, you guys can, you can really play an important role in also just recognizing if a person's had pain for a long time, then put them into that camp. And then one of the way I like to think about it is that you have a range of people. Sometimes it's very easy to diagnose that this is a chronic pain problem, and you can actually diagnose the mechanism, and you can actually start the treatment and everything. So for example, a really simple example would be shingles. So if a person's had shingles and they've recovered, and then they come to you 3 months later and they say, I've still got this terrible pain problem, you know that is neuropathic pain, because Dr. Elchin said there's got to be a lesion of the sensory system, the nervous system, that a neurologist would validate. You can validate that, and it's not going to be any mysterious thing. So that's, on the simple scale of things in general practice. And probably diabetic neuropathy or alcoholic neuropathy, these kind of things will kind of jump out at you. And then what will also jump out at you in the opposite spectrum will be headaches and chest pain and abdominal pain. I mean, those are really pelvic pain. Those are difficult problems. And to make sure that there's not a treatable cause and that you're not missing something, you normally need referral to secondary care to actually do that. So the take-home message here is that it's important to really play that role of making the diagnosis and then facilitating the diagnosis. So we get rid of the red flags. So we can think of red flags, the yellow flags, and then the blue flags and black flags. But you don't want to miss the red flags in a first presentation or somewhere that hasn't been well worked up. And so there are pathways. So pathways usually look at probabilities. So if a person's got neck pain without previous cancers and they're not over a certain age, etc., it's useless getting an X-ray. Deo in Canada looked at 4,000 neck X-rays done for neck pain, and they didn't find one bit of pathology, right? When those red flags were taken out. And so those red flag guidelines give you a high probability that you're not going to miss something. So you may be able to start treatment of chronic pain in primary care for those easier people, and then you need another system of stratification as to how badly this is affecting the person. So that's where you need a means to stratify. And so like the ACC guidelines, you've got the yellow flags, etc. And Jess is going to talk about the yellow flags, etc. So think in terms of stratification and think in terms of who needs referral. And so we need to be able to interact with secondary care so that we can get some of those treatable conditions ruled out. And then we need to be able to refer to a pain clinic once those have been ruled out and that person is distressed and disabled and not functioning well. So let's... So one of the other aspects is that I do the odd day in general practice. So, like I go up to Cheviot, which is a little rural place, and there's a great butcher there, and they close at 5 o'clock. And my last patient's 4:15. So if I get a chronic pain patient and I'm running a bit late at 4:15, I want to make the butcher, right? It's like, you know what I mean? And so you've got to look at your own biases and your own ability to manage these people, and you've got to have a strategy. You've got to have a strategy that you don't take it all on at 5:15 on a Friday afternoon. And so we can talk a bit about that, and it'll be great to get your feedbacks because you've all got your own tactics. Because these people who are really disabled with chronic pain, as John says, we don't, at Pain Clinic, we get the full package. Like they start off with kind of child abuse, and then trauma, and then there's maybe an addiction problem on the way, and then they've had a kid, and then SIFs has got involved, and multiple areas. I mean, more scenarios, but there are a lot, and you all know them. And then there's borderline personality disorder. There's a diagnosis down the road, and they can't see you because they've got no money to come to the GP, and so you've got to have a strategy in place to protect yourself, and also to give the person the time that they deserve, because we can't look at that 10-minute model or that 15-minute little interaction. It doesn't work. So I've talked about that earlier, and we've talked about that, and I've talked about this. So, you need to have the confidence that there are conditions in primary care that can easily be recognised, and so kind of identify them, so that you do have a strategy in place, and pathways or guidelines are also useful. And so I've talked about this, so especially the visceral pain syndromes, they do require secondary care to exclude the treatable pathology. And I don't know what experience you have with secondary care, but we're trying to educate secondary care, because again, you do have people in secondary care that over-medicalise. Everything's always a medical problem. They can't see the subtleties of the chronic pain person. They always want to do another investigation or another operation. So you've either got to avoid them, or you've got to kind of educate, or you've got to, steer the person through this this difficult pathway. And so we see a lot of people with iatrogenic harm, where people either themselves are trying to pursue a treatable course, so they spend thousands of dollars. So for example, a patient was in a gym and doing kettle weights, so this is big kettle weights, and developed a bit of neck pain, and the pain didn't go away. So went to colleagues of mine, and MRI is normal, but maybe we can find the source of the pain because it's unilateral. So then they did diagnostic blocks of the facet joint. Sort of mixed results. So then they did them again, and then they didn't really work out. So then that person said, well, I can't fix you, but there's a pain expert North Shore, so go and see them. He a whole lot of exercise that didn't work. Okay, maybe there's a guy in Wellington that can fix you because he's got an interesting approach. So then she went to Wellington. He couldn't fix it. So then, there's a guy in Melbourne, and he does, occipital stimulators and stuff. And then she didn't like the idea of a lot of electronics in her neck. So then we land up with her, once, so that was $29,000 later. So A, people spend a lot of money, and B, they waste time because it's a wrong pursuit. And then once the mechanism's explained, that's a lot easier to deal with. So, really, one of the other things, I don't know, when I started, I came to New Zealand from South Africa in about 93, and no computers, but we had these files, right? I don't know if any of you remember them. So you open a file, and then on the front it was problem list, and then so back pain, and then when it was resolved you crossed it out. But it was quite good because that every time you open it, I haven't resolved that problem yet. So it's really important not to abandon people with these pain problems, because they are persistent and they do need to go their full route. You need to take it to the nth degree. And so we've talked about delay, etc. This is Jess, is it?
This is you.
Is it still me?
But I can talk about it if you like.
They've stuck some interesting slides in for me.
It's the slide and the next slide are
Right.
components of the medical system.
Yeah. Bronnie's stuck some. Jess is going to talk to that one. Or Bronnie, yeah, because Bronnie stuck it in.
Okay, right. So in Canterbury, and probably I think in other areas around New Zealand, I'm just not so familiar, we have the health pathways web pages that we go to. And so we have a chronic pain page for Canterbury and West Coast. And on the chronic pain page, we have kind of, I guess, some directions for GPs in terms of what to do in terms of a pain assessment, and then also the referral pathway if you want to go further. So what I've done is I've copied and pasted across from the health pathway what we recommend to Canterbury GPs, because I thought it was just a useful guide in terms of pain assessment. So what we encourage GPs to do is start with the pain history, and this is where I was saying sometimes a pain diary is useful. If it's a new pain problem, then actually getting a pain diary over time could be really, really beneficial to look at patterns and to help you with doing differential diagnosis and things like that. Finding out, is this a new pain problem or is this a flare-up of something they already had? So if they have had a 10-year history of back pain or fibromyalgia or something like that, and they're presenting to you, maybe they're a new patient, or maybe they're not a new patient, but it seems to be a problem they haven't come in about recently or before, then maybe it's actually a flare-up of a condition that already existed. So getting that really thorough pain assessment in the beginning, and getting collateral information from family or friends or from others. And then doing a screen of the situation and using some of the kind of standardised tools like the Arebro. So we have a 6-page pain assessment questionnaire link, and I've actually brought the 6-page document along. We're running short on time, so I'm not going to put it up, but in the break, if anyone wants to look at it, and we can send it to you after today, it helps with guiding that initial assessment of the pain history and the current presenting problem with pain. So it's really useful. It gives you that pain diagram, but it also helps you to start to identify things like skin changes and some of those kinds of flags, if you like, that might indicate like a CRIPS presentation or something different that you want to get onto quickly. Do you want to add to that? And then that's the last part of the assessment. Yeah.
So great, thank you. The advantage of working in a team is that you just call on your team. And the other thing, when we set this up, Fiona said this was my team, and it's true, it is my team. But it's also Jess's team, Bronnie's team, John's team, and Lynn's team. So it's quite nice working in that environment.
It's a privilege.
It's a privilege, yeah. And so teamwork in general practice, really important. You know, get your nurse to do a whole lot of things, get your doctor to do a whole lot of things. Now, even your receptionist can be, they're quite smart, they know who's got chronic pain. So basically the take-home message there, is do a pain history and use open-ended questions. So I do that quite a lot. I'll just say, so if I want to know if there's anything associated, because I find that one of the most interesting questions, I'll say to you, okay, you've got pain that goes down your lower limb. Is there anything else, right? And I want pins and needles, or I want numbness or something, because then that's neurological. If they just say, no, it's vague and it's over the whole limb, then that's probably somatic referred pain. So you can get an idea by your questions of what type of pain is, because you can also look at the mechanisms of pain from your pain history, and you can get clues there. So if you've got somebody that's got true sciatica, right, so radicular pain in a narrow band, so it's a narrow band, not more than 5 centimetres, it should be lancinating or burning, set off by neural tension tests. The other vague pains that we call sciatica are usually somatic referred pain, so you can get a good idea. And so you can also say, is this more neuropathic pain with your burning things? It's not exactly diagnostic, and there are tools, they're validated tools for neuropathic pain, so you can start using that. And then, so your primary thought as GP, get rid of the red flags, and you've got to have the confidence to do that. And then lay your hands on the person. So we know for things like back pain where there's no neurological history, it's almost a waste of time to examine the person, right? Okay. Once you've got rid of a fever and neurological things and weird diseases and no metastases, no prior history of cancer, you're not going to gain much by doing it.
And
yeah,
can I just contribute there
Yeah.
that as a clinician you might not gain much, but as a patient sometimes it's actually very helpful.
yes, that's why I say you've got to lay your hands on
Yeah.
them. So,
Yeah.
right. Because people do like to feel, because we get the comment, he didn't even examine me.
Didn't even look at me.
Like, and that's the top orthopedic surgeon who looks at the scan with his legs on the table and says, I can't do anything for you. It's really valid, but look, to me,
Yeah.
but to that person it was a terrible examination, terrible thing. So you've got to, it's that caring aspect, and then that's the point that Ronnie's making there. So one of the little resources we've got is the International Association of Study of Pain, Stepped Care. It's a resource, and look at it, because the point I'm trying to make right now is that you need to stratify your people that you see, and you need to have some simple, easy tools. So Jessica's going to talk about yellow flags. So substance use, there's a little tool for substance use. It's not 100%, but it's useful. And if they've got Hep C and their cannabis levels in the urine are sky high, they probably are an addict.
What about medicine, analgesia? Does that come under
Pardon?
substance abuse? Does that include analgesia as well, especially with like a cannabis thing at the moment?
Yeah. So substance abuse would be opioids, benzodiazepines, cannabis, alcohol.
And prescribed medications as well?
Yeah, because sometimes it's well-meaning prescriptions and they're doing all sorts of bad things with them. So look at all the associated things. So anxiety, depression, activities of daily living. Jason's going to talk more about that. But all the yellow flags, all the work things. How's pain affecting them? Sleep, work, play, exercise. Pardon?
Are you going to talk about it?
No, I'm not. Those are just quick GP thoughts. There are one or two things that you really do not miss. So complex regional pain syndrome, so there are criteria for that. But at GP level, the overwhelming thing is pain that's out of all proportion to what should be happening. And then your little light should go on because you want to get that. And a lot of people can be managed in primary care with pain toolkits that Jess is going to talk about versus so you try and sort it out. I don't know, later on,
We'll cover that later.
the 15-minute consultation not going to work, so you've got to have a strategy.
Later we talk about managing the consultation and
Right.
quite a lot of depth.
I was just about to ask that because
Yeah.
I can take a good hour to do that.
Yeah. We will talk that through. Probably
Yeah,
there's one
we'll
point
have
on
some
there that we
interaction.
didn't that we will just say now quickly, and that's that 6-page document I talked about. That might be something you actually send away with the patient because you're not going to get through all of that.
I was a GP and I'm trained as a anaesthetist. I
Yeah.
know it's incredibly difficult to do a pain
Yeah.
assessment or a global
That's
one
right.
that validates the patient
Yeah.
in a GP time
In
slot.
15
It's
minutes.
almost impossible.
Later, after lunch, we have a whole section on managing the consultation, so we'll come to that.
And how to plan future.
Yeah.
I'm going to head over to Dr. Jessica Mills.
Okay, just quickly, how many of you are familiar with yellow flags already?
Yeah.
Okay, great. So if red flags are the serious pathology that we need to rule out, yellow flags are those things that we know contribute to poorer outcomes in chronic pain. And the reason that we want to look at them is because we want to see what is modifiable, but we also want to rule out where this person's coping really well so we can draw on those strengths, okay? So we know that there are things that contribute to basically poorer outcomes, and we need to see that they're there because those are the things that we're going to either treat ourselves or refer on for treatment. So yellow flags were developed by Nick Kendall and colleagues, and the Arebro questionnaire that Ian mentioned very briefly before actually sort of maps quite well onto some of these things, so that can be a really nice quick screen if you don't feel you have good time to cover all of these things. And the list of these things is actually quite large, and they overlap between categories. So there is a link in the resources we hand out to a very long list of things, but just quickly, you're looking for things like attitudes and beliefs around their pain. Do they think that they're hurting themselves and re-damaging themselves every time they feel pain? Okay? Are they avoiding movement because they think they're really harming themselves? Do they believe that it's a really biomedical problem? Do they have that external locus of control that was mentioned earlier? Okay, those are the attitudes and beliefs that you need to be looking for. Are they looking for something outside of themselves to fix the problem? Are they resting? Are they spending a lot of time resting or getting other people to do things for them? That behaviour in response to often those beliefs they have around pain, that it's dangerous to move. Looking for things like that sort of behaviour. Other behaviours might be self-medication. So if people are self-medicating, often that's just stress related, but it could also be pain related or sleep related. They're self-medicating because it hurts so much they can't sleep, so then they want to sleep, so then they drink or use cannabis or what have you. Compensation. Now you mentioned this before around compensation. Compensation is a problem not just because of the secondary gain of I'm going to get money if I'm unwell. Being involved in a litigious sort of ACC framework means that you're constantly having to prove there's something wrong with you. And our patients have this invisible problem. They already feel fairly invalidated a lot of the time because they've had all these tests that show nothing. They think that they're making it up themselves half the time. Their workplaces don't necessarily believe them, and they feel like ACC doesn't believe them either. So they get into this battle to prove there's something wrong, and they become incredibly entrenched in this. The longer you're in this entrenched, angry system, the more that you're going to become stuck in my biomedical framework of proving that there's something wrong. And so shifting into a self-management framework can then be very difficult. So this is really a yellow flag that you need to look out of, and it's also a place where treatment can be really important for some people. And sometimes it's the case manager themselves that needs a bit of education here. Diagnosis and treatment. If many doctors have told this patient they've got something terribly wrong with them, you've got endometriosis and you're going to be infertile and we need to take out half of your internal organs, that's terrifying for patients, and they are really thinking there's something terribly wrong with them, and then they come and see you and you say, oh well, actually no, it's just your pain system. They're not necessarily going to shift away from that belief that your diagnosis is more valid than the 5 specialists they've seen before you. Okay, so it's about looking at what are all the other diagnoses that they may have had in the past, because actually that can inform their attitudes and beliefs. Emotions. Is this person really anxious? Is this person really unhappy? Very fearful. If you're low and anxious, you don't really feel like doing anything, so you don't do anything, and you stop engaging in behaviour, you become more deactivated, and then it's more painful to move. So actually sometimes it's about getting the person to do more, but sometimes it's about maybe I need to treat some of the moods and emotions that are going alongside pain. And we know that these low emotions are useful in helping our body rest and helping us withdraw from a survival mechanisms, but not that helpful in a chronic pain situation. So flagging these things can be really important as well. Family is really key as well, because we know that families that are either overprotective, so too solicitous, don't do that, that will hurt you, let me do that for you, or oh poor little thing, no you don't do that, you sit here, I'll get you a hot water bottle, I'll bring everything to you. Or on the flip side, invalidating, oh harden up, oh here we go again, talking about your pain, never hear anything else, just I have to do everything around the house because you're in so much pain. Those two systems can be really unhelpful for the family, for the patient, and it's hard work for families too. So sometimes those family systems, we need to ask some questions around those as well to figure out what might be happening externally outside of that consultation room for that family to maintain some of those problems that we're looking at. And then work. If your boss isn't supportive, if you really hate your job, if you're in a workplace, we know that's particularly physical workplaces for back pain and other pains. People really believe that they can't get back to that kind of work, and also you're not very motivated to get back to a job that's both unsupportive and not that enjoyable. So there's loads of different yellow flags that we could look out for, and what we're looking for basically is more of them. The more there are, the more the problem. It's cumulative. One problem it's probably overcomeable, but when there's lots feeding into that patient's system, then that's where you're going to have more poorer outcomes. So there are lots of questionnaires that we can use to help pull out these yellow flags. You can just go through with a checklist and sort of mark them all off, but one of the best ways to find out about some of these yellow flags is just ask your patient. What do you think is happening inside your body? What do you think is causing your pain? What do you think happens when you move? What do you think your diagnosis means for you? How are you feeling? That must be hard. Does it stop you from doing anything? What does it stop you from doing? Why can't you get back to work? What stops you? It's really as easy as just asking, and you might, as you go on, you sort of pull out a few juicy questions that you sort of use, because again, in 15 minutes you can't necessarily look for all of these, but there's sort of a few key ones you can pull out from each section, or you could use things like the Arebro, or both. Anything else anybody wants to add?
No, that's good.
Okay. Ian.
Yeah, we're going to flick through this. Yeah, so when do you refer, these are our criteria at the pain clinic. We obviously want the duration to be there, because otherwise problems that might go away will go away. We want the red flags reasonably ruled out. And then it's useful for you to have started some form of treatments. And so that's where the whole stepped care and the stratification comes into play. And then that's obvious what Jason's been talking about in activity daily life. And so there are tools for assessment, and so we don't want the primary problem to be something else. So in other words, can they engage in the kind of strategies that we're going to employ? So if a person's predominant problem is addiction, then we generally want them to be referred to the community alcohol and drugs to get that sorted out first. So we'll facilitate that if we communicate with them once a month. If the primary problem is mental health, then we may be able to work with the mental health people, but we don't want their primary problem to be something else. If they're actively undergoing investigations, or there's something that is offered to them that they can't get. So in other words, the surgeon has said, you definitely need surgery for your back problem, but ACC won't cover it. It's very hard to shift them until that's been resolved. So generally, those are kind of our criteria.
So when we're thinking about when to refer, once you've ruled out those red flags and you think chronic pain is the problem, basically when you start feeling stuck, when you start noticing that there's too many yellow flags, or that you don't feel like you can adequately treat them in primary care, if there's an escalating sort of medication regime, or the patient's very resistant to changing that medication regime, and you're sort of feeling that actually it's not very helpful for them, that will be the time to refer. And if you're not sure, ask. Ring up whoever you do your referrals to and ask them. They'll be pretty quick to rule out people that they think you can manage in primary care. Yes, and they can provide advice as well.
Okay. So, very quickly, the wonderful thing about working in an interdisciplinary team is that we're all in the same building on site, and we all have access to each other all the time, which is a real privilege. So I just want to quickly run over what actually happens in a comprehensive pain assessment, certainly at what we do at Burwood. And we've talked about the biopsychosocial model, and that means that we are looking at everything from a total biopsychosocial perspective. We're trying to get the biggest picture we can of how pain is affecting this person's life. It's really useful for your patients to know sort of what to expect when they come into a service for a tertiary assessment, because obviously it's not going to be 15 minutes. In fact, we have the absolute luxury of having an hour each with the person. But that means it's a really long assessment for them, and quite often if they've been through ACC assessments before particularly, or other pain assessments, they've done this a few times, so it also can be quite wearing for them. But it's likely, in our service they will have a medical assessment, a functional assessment and a psychosocial assessment. The medical, obviously there's been a lot of talk about that already this morning. Really reviewing the situation, reviewing the pain history and the current history, and often it's a time when all those extra sensitivities and other parts of that pain presentation get pulled together, because quite often people have, as John said, have had really fragmented, they've been to the rheumatologist, the orthopaedic surgeon, the gut person, and now it's all being pulled together. So quite often that happens within our service, and the diagnosis is being confirmed, and another opportunity for validation with those patients, and sometimes it's an opportunity to educate a little bit in that moment as well. And of course the other big part for the medical team is looking at are there medication opportunities, what's been done before, and what may be worthwhile moving forward in terms of medications, and obviously ruling out is there anything else that needs to be done before we move forward with chronic pain management. From a functional perspective, mostly that's done by physiotherapists like myself, and moving away from a traditional sort of musculoskeletal or assessment, we are looking at specific pieces, but it's an opportunity to observe the behaviours that are prevalent when someone has chronic pain, such as avoidance. So we're getting them to do things, we're taking measures, functional measures, but we're getting them to do things and observing those behaviours, and an opportunity to ask them, why is it that you don't like doing that? What's happening for you in this moment? What are you thinking? So we are sort of bringing in that cognitive side of it as well. And our key part of that is really focusing on the impact of pain on their function. The other thing I didn't mention there is it's really useful if family members or support people do come along with our patients, because it gives us an opportunity to have a look at that relationship and the impact on the families and the partners, and we sort of see some of that solicitous behaviour or some of that toughen up kind of behaviour interaction as well. And then the psychosocial part of the assessment really cleans up everything that everything else. So that broad influence of everything else that's happening and the impact of pain, their beliefs, expanding on mood and sleep and anxiety and work and relationships, and all the other factors that are affecting that person. Have I missed anything, anyone? No, we're good. And then moving forward from that, at the end of the assessment, what happens with our team is we give the patient a bit of a breathing space, and we all meet together and put everything together and have a conversation about where do we go from here. And it's really based around what the barriers are, what the person's beliefs are. Are they actually ready for a self-management sort of focus? If not, what needs to happen to help them to get to that place, or are they going to be able to get to that place? And the other outcome measures that we look at is we obviously have psychometric tools. We use the EPOC system, and as I said, we have functional behavioural outcome measures as well. And it's all based around what does that person want? Where are they going? What's their expectation? And then we will formulate whatever management process program, whether that be a one-to-one or a group program or referral back into a community sort of situation. So that's where we go from there.
Great, yeah.